Hello guys, welcome back once again to the RxTX Pathology channel. I'm Dr. Ranjit, and here we are going to see a very interesting case discussion. We'll look at the theory as well as slides, how to identify polyoma virus nephropathy, especially in a renal transplant patient. If you have a segment of renal pathology or nephropathology in your college, I'm sure that this is kind of one of the most important thing which is expected at least from a postgraduate to pick up. You are not expected to go and classically defined, which is acute rejection, chronic rejection, can score them. But at least polymer virus nephropathy is something which is like a spotter for a postgraduate, and I feel that every postgraduate should be able to pick up these at least, especially when you have a nephropath fellow or a nephropathologist coming as an external. This might come handy, right? So first, like I said, we look at the theory part, what to focus on, where to focus on, and how to score. Scoring might not be very much important, but I would want to also you to know understand how scoring is done, so it's easy for us whenever you see a case that might give an extra brownie points for you in the exam, right? So first thing, polyomavirus nephropathy is primarily a tubular interstitial disorder. It's not going to primarily affect the glomerulus, right? So let's keep set aside the glomerular part. So whenever in light microscopy, when you're seeing a focal lesion, because most of these polymovirus nephropathy, when you have a core of biopsy like that, it'll be like here, it'll be like here, it'll be concentrated. Need not be always, but most of them will be concentrated around few foci. This is a very classical finding in a polymovirus nephropathy, especially in a very low power as well, right? Like I said in the initial start, it's going to involve the tubules primarily, and also you'll have a little bit of interstitial nephritis as well, right? So it's a tubular interstitial disorder, you'll have interstitial nephritis, and also it's going to primarily affect the tubules, right? So what we are going to look at the tubules and what we are going to look at the interstitium is what we are going to consider in the near future, right? So most important thing, especially when you have a kind of a clinical pathological meet with a nephropathologist, you have to tell them whenever you're suspecting a polymovirus nephropathy, I need at least one core where the medulla is better sample than the cortex, because like I said, it's more of the tubular interstitial disorder. Medulla is something which is very, very important for me to assess the importance of tubular interstitial disorder. So sampling of this medulla is very, very important. Like I said, this has to go to every nephrologist who is going to take the kidney biopsy, because these are transplant rejections and it's very, very difficult to take a rebiopsy. I'm not saying you won't find that in your cortex, but medulla gives much confidence in scoring and everything, right? But like I said, it's primarily the interstitial nephritis and the tubules, right? Interstitial nephritis is very non-specific. You might have an interstitial edema, there'll be edema there, and there'll be infiltration of lymphomononuclear cells, right? So this is what you're going to see primarily in the interstitium. A little bit of plasma cells. Sometimes you might see neutrophils and eosinophils, but not much, right? And these are more predominant in the early stage of the infection. Mostly it's going to be inflammation, edema, mononuclear cells, and be patchy. The most classical finding or the hallmark finding is what we're going to look at the tubules. Tubules might have extremely varied findings based on the stage of the lesion. I can have a complete dropout of the tubules, completely desquamated tubules, sloughed off, flattening, anything can be there, right? So the first thing, where the tubules are there, it might kind of desquamate, come outside. It may kind of completely flatten out. It can extremely flat, can desquamate, and completely have a dropout. Nothing will be there, or it will be completely necros, right? So when you look at the tubular epithelial cytology, right, the cytopathy, which is very classical for case of a polymovirus nephropathy, which might actually be absent in the early stage of infection, right? So when you take a tubular cytopathic effects, this what actually tells us, okay, I'm going to deal with most likely a polymovirus, right? So first is cell enlargement. Cells will definitely be enlarged, so you'll have increase in the cell size. Cellular enlargement is by default the characteristic finding, because imagine a virus is going to come into a tubule and replicate into a tubule, right? So obviously by default the cell has to increase in size. Nuclear hypochromasia, when you look at the nucleus, you will have hypochromasia. It will definitely look darker, and it'll have anisonucleosis. Say these are something which I cannot miss. You'll have different in the nuclear size morphology, and you'll have chromasia, hypochromasia as well, right? And then the inclusions. Inclusions are of varied things. I can have multiple things. I want you to listen to everything here, because all these points out, or at least a clue for me to go with an IHC where obviously the polymerase can be easily picked up as compared to the histomorphology, fine? So you will definitely have kind of an basophilic granules. These are basophilic inclusions. So I might have very tiny basophilic granules, one or two of them. That should be more than enough for me to suspect. Or sometimes you can have a complete replacement like a ground glass appearance, right? You might have a ground glass appearance as well. Okay. Again, it's going to be basophilic. It will not be eosinophilic ground glass appearance. It will be completely basophilic clearing of a ground glass appearance. That also can be seen, right? Or ground glass appearance, nothing but, see, this is ground glass appearance. I might not be able to exactly replicate. Yes, wait. This is what I called in ground glass appearance, right? So what it means is the nuclear chromatin kind of goes to marginate and the center completely becomes clear, kind of like a translucent appearance of the nucleus, neither transparent nor opaque. That's a ground glass appearance. You will not see halo. Chromatin changes, smudging, coupling, your peripheral margination, like I said, can be seen. Okay, margination of the chromatin. You can see your extremely becoming clumps. That's possible. You can see clumps of chromatin. You can see smudging of chromatin. That also is possible with respect to chromatin changes. But any basophilic granules or a complete ground glass clearing appearance is something which is going to call for suspecting a BK virus nephropathy or a polyoma virus nephropathy, right? So here BK virus might also be seen in the tubular interstitial cell, right? The same thing. When I have kind of same thing in my urine cytology, we call it decoy cells. Again, it's going to be kind of a completely ground glass clearing or clearing of the nuclear chromatin. We call it decoy cells. Again, a suspicion of an BK virus nephropathy, right? Now, these are the nuclear changes, and these are the few interstitial nephritis changes which can see in case of an polyoma virus nephropathy, right? Like I said, it doesn't end without us looking at the slides, and let's see if we can identify this, and also have an immunohistochemistry for the same polyoma virus SV40 clone. Let's see if we can pick them up. It's a very simple diagnosis, right? Thanks to the slides. Slides are from Leech Pathology website. They have an amazing source of slides if you want to go and have a look at it, right? Okay, so first of all, let me bring the mouse here. Okay, give me a second. Just sorry for it. I hope it works. Okay, let's ignore it. Fine. So now you can see two core biopsies. Definitely, it's including a little bit of medulla, not much, right? It is predominantly the cortical areas, right? So now, if you're suspecting polymovirus nephropathy or if there's a clinical suspicion of polymovirus nephropathy, first thing is look at the areas like this where you're having good amount of concentrated things. Just give me a second. Yeah, sorry. You have good amount of concentrated, very kind of falling out nucleus and lots of interstitial inflammation. That's a place where you can easily suspect a patient with polymovirus nephropathy, right? Let's zoom in here. Definitely here you do have interstitial edema. Yes, good amount of lymphomononuclear infiltrates is there. I'm not looking at these tubules. I'll show the tubules very soon. These are decent, pretty decent tubules, right? Let's go here. Let's go here. Let's go here. Look at this. Again, good amount of lymphomononuclear infiltrates here, right? Definitely. Fine. Now, let's go and zoom into the tubules. First thing, it's definitely hypochromatic. You must have seen multiple normal kidney biopsies by now. There's definitely good amount of anisonucleosis, hyperchromasia is there. And if you zoom in further, you're not able to zoom in further, even in this power, let's scan through, you will definitely find kind of inclusions. Look at this. Kind of a basophilic granule there. Yes, definitely. That should arise a suspicion of an polymovirus nephropathy. Right? Let's zoom in, let's zoom on, and let's go to one more area where I can see it much more clear. This is tubulitis, right? You have the entire tubular epithelium kind of getting sloughed off, and the inflammation is kind of entering. This is a mononuclear cell, right? Kind of entering the tubular basement membrane. Look at this. Look at this. That's a beautiful neutrophil kind of going into the tubular epithelial cells, right? That is tubulitis. See here, one is kind of going inside here, right? Tubulitis. Again, look at this. There is anisonucleosis by default. You'll accept that this is not the same size here. There's anisonucleosis. WBC is going inside it. So I can definitely brand this as tubulitis. Something of tubular interstitial pathology is going on. Like we saw, I can see a little bit of eosinophils here and there, patchy eosinophils here and there, which can be seen in the interstitium. Neutrophils can also be seen here, right? Again, look at this. Will you accept that's an inclusion? That's a huge cell, right? Kind of granulation. This is more of clearing. This is a very classical inclusion body, which should give us right suspicion of an polyoma virus, right? Let's go ahead. You will see them. See, once you see one polyoma virus, you go and scan through it, you will definitely find more things that suggest to have the same nephropathies. That's all, right? Again, classical tubulitis going inside, kind of completely destroyed. The entire tube is kind of completely destroyed, right? Okay, look at this. Such a huge, smudged, huge nuclei, right? And definitely it's a smudged but it should have inclusion bodies by default. Okay, so look at this. Clearing is there, right? I hope you can appreciate this clearing, right? Again, tubulitis here. You can see a little bit of kind of smudging here, right? So all these are suspicious of an polymovirus nephropathy, right? So how to score a polymovirus nephropathy? Though, like I said at the start, this is not required for a normal general PG student, but if you're a nephropathology resident or a little bit keen into nephropathology, this might definitely come in handy, right? So we do have polymovirus scoring. There are two important things in polymovirus scoring. Most of the polymovirus scoring is based on the load of the polyomavirus. We call it a PVL load, polyomavirus load, PVL, right? It's PVL scoring, right? So let's go back to the board again and let's come back to this very soon, right? So when you come to the scoring system, there are two things. One, you score the polymovirus load. Along with that, you add the Banff classification for the tubular interstitial fibrosis and in nephritis, right? I'm not going into that part. That's a separate thing. We'll discuss sometimes separate, right? Now let's look at the PVL scoring alone. Scoring, we call it a polymovirus load. That's polymovirus load scoring, right? So I would say that this is much better appreciated when you go with a marker than going with simple histomorphology and to identify them. So I would call something as a tubule involved with polymerase, right? So it's a semi-quantitative method. We score them if it's 1 less than or equal to 1% of the tubules are having. If it's 2, we call it 1 to 10% of the tubules are having. 3 polymerase, more than 10% of tubules are having the involvement of the virus. So how will I call it positive or involvement present, right? Either I have a very, very typical inclusion, okay, a typical intranuclear viral intrusion which is seen on a light microscopy, then I can call it positive, or I have a positive for an SV40 antigen. Okay, if this is positive also, I'll be more than happy to call it, but definitely an immunohistochemistry is much more sensitive and easy to pick up compared to a histomorphology scoring. But yes, we did see few classical intranuclear inclusion, basophilic granules, clearing, smudging, chromatin, everything. All of them I'll include as positive thing, right? It's not that if I have a tubule, every cell here should be positive to call me involved, right? Let's say that I have some 6-7 tubules. In this, I have one classical inclusion. I'm going to call it 1, right? So this, let's assume that if only 1 is involved among 10 tubules, I'll call it 1 or less than 1, right? So it's the percentage of the tubules involvement and not the percentage of the cells. It's very difficult for you to consider cell involvement. If one tubule is involved, one cell of the tubule is involved, I'm going to call that tubule is involved, right? So this is the percentage of the tubules which are involved, and how do I call it positives based on this, right? Like I said in the start, it's very easy and comfortable for us when you go with an IHC of an SV40 antigen. The Leech Pathology website also has an IHC slide. Look at the beauty of this slide. There's actually 10%, very strong positivity. Look at this. Such amount of positivity is there. It's a clear nuclear positivity. Don't take anything as a faint cytoplasmic positivity or membrane positivity. It has to be a nuclear positivity. If it's nuclear positive, I'll definitely consider that as a positive thing, right? Here it's more than 10% of them are positive. This exact slide is a PVL scoring of 3, right? So I'm not including the Banff classification for interstitial fibrosis here. We'll definitely look at that sometimes later, right? That's a clear positive, right? That's a very, very good positivity here. You can see them, right? Okay, so that's about this case of a polymovirus nephropathy. This is very important for a PG aspirant who's sitting for the exam, be it a MD or a DNB exam. This might come in handy. If you're first time here, so click the subscribe button and share it to your friends who are fellow pathologists and who are very maniacal about the pink and blue. Let's learn more, and all the videos will be uploaded on the RxDX app as well for a later viewer. Right? See you soon. Till then, bye bye from Dr. Anjit. Bye bye.